First thing that's going to pop up is, remember, again, don't be intimidated by this by this test. It's still the same stuff, but what they've done is they've given you a chart, right? They've got your nurse's notes. So the one thing that is going to need to happen is, and I don't think people realize how important this is going to be. There's a couple of things. Those of you taking notes, make sure you write this down. The first thing that you want to do is you want to make sure that you're reading, that the speed that you're reading at is increasing. Because if you notice, the old questions were pretty much 3 lines, 4 lines, max. Sometimes it was a one-liner. In this situation, you've got to get a lot of information in a short amount of time. So understanding that reading speed is something that you're going to have to work on. You still have 5 hours, which is plenty of time, but you're going to have to read and absorb what's more important, right? Then you're going to have different sections. Like you got your nurse's notes from med surg, you got vital signs, and you've got lab results. Now, in this situation, they're giving you what normal is, right? They've given you what normal is. I don't expect you to get all the lab values. So you must know lab values. So, and we've provided all of them, right? This is, again, nothing new. And I want to take away that anxiety and that fear, because you've got a sheet of laboratory results that we've already given you. So you should already be familiarizing yourself with what normal is. Vital signs, temperature, pulse, respiratory rate, blood pressure. We've covered all of this. Right? So now, really, we're looking at nurse's notes. So now, in this situation, we're not going to read the bottom first. We're just going to read the entire note, okay? So, for instance, the client reports chest pain of 5 on a scale of 0 to 10. The pain is sharp and occasionally radiates to the upper back. It makes it difficult for the client to take a deep breath and increases with movement. The client recently recovered from an upper respiratory infection 1 week ago, but still has a persistent dry cough. Lung sounds are clear and no shortness of breath is noted. A high-pitched grating sound is heard over the left lower sternal border, okay? No peripheral edema or extremity pain is noted. So now we've got to see, what could this be? What could this be? The nurse is reviewing, now we got a Bowtie question. So nurse is reviewing the client's assessment data to develop client's plan of care. Complete the diagram by dragging from the choices below to specify what condition the client is most likely experiencing. 2 actions that the nurse should address, and 2 parameters the nurse should monitor to assess the client. So check this out. We've got vital signs now. We look at that. Vital signs they seem okay, right? Except for the temperature, not too bad. Laboratory results, okay, no infection, platelets look good. Trope is less than 0.03. So now we know it's not an MI, right? So now we look at these notes and we look at the clues that they've given us. First and foremost, what we must do is we must figure out what our diagnosis is. What is our diagnosis? Well, now this is where they start to become a little bit more real life, but this is what I've taught you. Pericarditis, we've covered it. Pneumonia, we've covered it. MI, we've covered it. Pulmonary embolism, we've covered it. We've covered all 4 topics, have we not? We have. So again, the medicine portion of this is still medicine. It's just the way they're asking it. So what condition do you think this is? Well, can we start with pulmonary embolism and say, well, we have no shortness of breath, lung sounds are clear. So can we eliminate pulmonary embolism? We're not tachycardic, right? Think of all the signs and symptoms of pulmonary embolism. We talked about it. We did a whole lecture on MI. We did a whole lecture on MI. Where is this pain happening? Is it radiating? It's sharp, occasionally radiating to the upper back, makes it difficult for them to breathe. But what in the labs tells me it's not an MI? And we talked about this. Troponins were normal, right? So now you're like, wait a minute, it could be, this is how you do a differential diagnosis, but I've taught you this. I've taught you this. So now I look at myocardial infarction, I say, yeah, you know what? Maybe there are some overlapping signs and symptoms, but my tropes are normal. Pneumonia. If this patient had pneumonia, tell me what you would hear. Do you think we'd hear something in the lungs? Probably. We'd probably hear crackles, fluid, right? You think the fever would be low grade, like 99.5, or you think it'd be like 102? Probably higher, right? Infection. And no shortness of breath is noted. But we've got some sort, so right now, can we just say that we've eliminated 3 of the diagnoses just based off of the information that was given to us? But then we go and we say, hold up, we've got a grating sound, a high-pitched grating. What do you think that it would give me another word for high-pitched grating sound? How about a friction rub? Yeah, you see that? Friction rub. And where is it? Left lower sternal border. Wait a minute, did we learn that? Erb's point? We sure did. We sure did. So now I've sat here and I've determined between the 4 that I know it's not a PE because my heart rate is normal. The chest pain or lung sounds are clear, no shortness of breath. I got rid of an MI because the troponins clearly let me know that. Pneumonia, we don't have any lung sounds and we don't have a high fever. So now I'm stuck with pericarditis. So now what I do is I take my pericarditis and I drag it into potential causes, right? So that is something where I've taught you every single one of these. So we know we've got a friction rub. Good, I'm glad you're getting it because it's not really that tough, right? But we've learned all of this. It's just the way they're asking it, that's all. So now I look at this and I go, okay, administer antibiotics. Well, we don't have really, the fever is probably from the pain, but what are we gonna do in these situations? What actions are we gonna do first? Well, and administer antibiotics, that would probably go with pneumonia. Administer sublingual nitroglycerin, that would probably go with myocardial infarction. Encourage the client to sit up and lean forward. Wait a minute, do you remember our acute pericarditis lecture? That patient came in, they said, oh, it feels better when I sit up and lean forward. So maybe we do that, right? Maybe we encourage them to do that. Provide teaching for long-term anticoagulant. That's probably going to be MI or that's probably going to be pulmonary embolism. Administer colchicine and a non-steroidal anti-inflammatory drug. Whoa, did we not talk about this? Did we not talk about this? Yeah, absolutely. Now, what are we going to monitor? What are we going to monitor moving forward? PTT, where are we going to see PTT? We're probably going to see that with pulmonary embolism. Good. Melena, wait a minute. This person's on NSAIDs. What do we talk about NSAIDs causing? Ulcers, right? Upper GI bleed, right? So you think I'm going to monitor? You think I'm going to monitor that? Absolutely, I am. And then we've got sputum cultures, probably going to be with pneumonia, cardiac enzymes, myocardial infarction. How about that muffled heart sound? Because we've got inflammation around the heart. And what do we not want it to lead to? Exactly. Look at how much information you have here. And now people are scared of this? Come on. This is not as hard as people make it out to be. So there's your bow tie. There's your bow tie. So how are we feeling? Bam.